I actually work in the School of Nursing at QUT. And my background was that I originally started nursing in community care and in rehab, etc., where we were faced with a lot of chronic wounds, as you can imagine. I did do a short decade of a deviation into midwifery and came back again. And I've been working both clinically and then for the last 10 years primarily in research looking at chronic wounds, which is my love. And my second love is my very first research job was in a centre for one of the JBI Centres for Evidence-Based Nursing and Midwifery, and I love evidence-based medicine too. So it's wonderful to be able to combine the two in this project, which I will tell you about. I know that many of you here, and I'm trying to condense what I normally would say in 5 hours into 90 minutes here, so I'm cutting certain bits. Many, I think, are from all over the place, and also we've got a few people from some very isolated areas. Is that right? Yep. And I think we have a very big, large range of skills. So please stop and ask me questions at any time throughout the afternoon, or if I'm covering stuff that, you know, you're dreaming of in your sleep and you don't want to hear about that, just also let me know as well. So what we're going to do this afternoon is I'm going to tell you a little bit about the Champions for Skin Integrity program. Has anybody been to a CSI workshop in the past? Not one. Okay, good. And I'm going to give you an overview of resources kits and how you can access other resources for your workplace. We will go through a quick overview, and I mean a very quick overview of an update of the evidence on wound care for various different types of common wounds. And then I think the best way to learn is always actually to try and do it yourself, which actually covers two aims of this session, is finding out where to find the evidence and how to actually get it into a care plan at the end. So the background of this project is we all know that actually wounds increase in prevalence with age. And I have predominantly worked with older people, and our whole population is ageing. And we know that's because our skin sadly goes downhill. Once we get over 30, it's all downhill, I'm afraid. And we all need to start moisturising. Once we hit that 30 base, our skin becomes less elastic, thinner, you know, it's less resilient. Our immune system eventually slows down. It takes us longer to heal, although it doesn't mean that we don't heal. When you actually look at studies of healing rates between older people and younger people, they have the same healing rates. They might just take 3 times as long as a younger person to heal, because things are a little slower. And we know that there's actually a whole heap of evidence-based guidelines out there on different types of wounds and in skincare. And I'm hoping that, I hope you can see some of that. Some of those covers might look a little familiar to some of you. Yes, some nods, which is great. But one of the first problems we had in this project, where the main aim was really to help people get evidence into practice in all sorts of settings, was that there's an enormous number of evidence-based guidelines. And when we went and we thought, well, how can we help people, you know, access information quickly, easily, whenever they want it? They might only see an unusual type of wound, you know, once every 6 months or something, and they just need to go back and check. And they really don't want to spend half an hour searching for that evidence-based guideline and then going through the 300 pages of that evidence-based guideline to find the one bit of information that they want. So what we decided to do in this program, basically to address that, was to do evidence summaries. We found that with common wounds, we went out and we did a survey and we asked people what they most were faced with, and what they were faced with was skin tears, you know, a range of leg and foot ulcers, pressure injuries, of course normal acute kind of wound bed healing, and, you know, some associated topics like skin care and nutrition. And we came down to 8 core areas, which I'll talk a little bit more about later. And we decided we'd do an evidence summary from the guidelines in those 8 areas, because even when you cut it down to 8 core areas, pressure injuries, for example, you know, have about 6 sets of guidelines. There's a set for the equipment, there's a set for the cost effectiveness, there's a set for prevention, there's often a set for management. There's that lovely new set that was released in 2014, which is an international one, which covers a lot of that problems, but it's still a lot of work to actually find them all and get them together. And we tried to make 1 or 2 page summaries of the primary, strongly based, evidence-based recommendations for each one of those 8 areas, so that you've all got somewhere quick to look up and easy to find. So there's actually been a lot of research on why evidence isn't put into practice, and I'm sure you're very familiar with that, and usually it's knowing where to go or having the time to get there. Difficulties with access. So all those reasons often limited that. And then I find that the other big issue, point 1 and 2, I often find is altogether in limited access, is changing practice and culture. So if you trained in the 70s like I did, we were taught to do very, very different things to what is recommended now. I went around rubbing backs, causing injury. I think we even did weird things like putting egg white on wounds and blowing it with oxygen, all sorts of weird things, which had absolutely no grounding. Yes, I'm glad someone else can remember that sort of thing. So, and you know, it's funny because some things are starting to come back, you know, it goes round in a big circle eventually. Because I really think that wound care is one of the most, you know, witchified areas of nursing. There hasn't been a good number of studies that proves any particular type of wound care is much better than another. And I mean, we'll go through that in a minute. But and everybody has 1,000 different types of things that they like to put on them. Yes.
One thing I can't up is sunlight on wounds. Because I really need vitamin D and all that sort of stuff. And I don't know, has there been any research?
Yes, I will address that later on, so hang on. So the aim of this original program was literally to get evidence into practice, and by doing so, of course, decrease the prevalence of wounds and improve the health of our clients. To do that, we decided we put together the Champions for Skin Integrity model, and what we based it on were strategies that have been shown in other health interventions to work. It doesn't have terribly strong evidence because, again, not many people have done that many really good quality studies in the area. But all of those strategies up there, most there, except that last point, have got some evidence in the literature that they work. We relied on teams of champions in each organisation. Now, if you work in a small organisation, you may be it. You may be the champion. And you're all here today because hopefully you're interested in skin integrity, and so you are the champion. But if you're in a larger organisation, what we found was that to make it work, we really found we needed multi-level teams, by which we needed a champion at the EN level and at the RN level and the educator level, and we needed a champion at the manager level, and we needed a champion at the person who holds the purse strings level. And they all had to be on that team, working together as a team, because without one person, if the RN is just making a decision, then she often gets blocked at another way. Whereas if you've got everybody on a team and you make a decision to implement a change in practice by the full team and they've agreed with it, you're much better off. It means that everybody in a larger organisation also usually has a peer that they can go to put forward their thoughts. Yes?
Are there many doctors on that team? So I'm saying in general practice that the doctors prescribe a particular type of wound care, which I find is the best way to go.
Yes. That would be our smallest number of participants. They were always invited. They have been always invited. I've been doing this since 2009-10 every year. And I think when I last looked at the stats, we have about 1.5% of our teams are GPs.
You've got no specialists on there?
No, but we do have specialists on the team. I find that each team is very representative of the workplace or the organisation they work at. We have a lot more specialists on the team than we do GPs, actually, because, you know, the diabetic foot specialists would come in, vascular surgeons, etc., are quite happy usually to be involved because it, you know, they would like it put into practice too. We relied on linked clinicians, and this was particularly for areas that were isolated or did not have expertise in a whole lot of areas on their team. So you may not have easy access to a high-risk foot clinic, and you may, I'm not sure. So what we found was in areas that were isolated and they needed to have a whole range of expertise on tap when somebody walks in with a funny leg or foot ulcer. If we actually invited the nearest possible expert in that area, asked them to be on a multi-D or be an official linked clinician for that practice or that organisation, it meant we would ask them usually every 3 or 6 months, maybe only twice a year, to be involved in a teleconference or a meeting together, so where people can talk about their goals. It saved a lot of time with people all doing the same thing individually but not knowing the other person. Saved a lot of time with resource sharing and getting a bit more of the logistics organised. And it meant that when somebody did walk in, that the person on the ground had a list of the experts who were happy to be contacted for advice if it was a particularly complicated wound. So that usually meant that we also had to sort out funding arrangements. So the organisation had to be happy that that person would be called automatically instead of waiting 3 weeks until you found the right person, and that they would be willing to, you know, they had some arrangement in place for paying for that time. Or some people volunteered their time. So it really was very individually tailored. resources we'll go through in a minute. We relied on clinical decision making and support things, which is in your research kits, and we'll go through. We relied heavily on audit and feedback cycles, because without feedback, people aren't motivated to do anything. If you're on a diet for a month and you don't lose a single gram, you're not really motivated to keep going, are you? And I find in this area, because we're trying to prevent wounds, a lot of these measures are to prevent wounds, you don't get the feedback. When you're healing a wound, it's great, you've got immediate feedback. You see it heal, gets better. But when you're trying to prevent wounds and you're asking staff week after week to put in all these preventative measures, or your clients week after week keep wearing their compression hosiery, don't they love doing that? They need feedback. And so having that feedback, and without audit often there isn't any feedback for the staff, also for the patients, auditing of their charts. People love to just see their photos over time. If somebody goes to the trouble of putting them on a little sheet and watching it, and they're all nicely sized, so that they can believe that it is getting better and gives them the motivation to keep going. We also relied heavily on awareness-raising activities, which, as I said before, actually I haven't really seen evaluated anywhere, but without communication we can't ever get anything done. And so each area would set a goal, or each organisation, and at the moment we've, over the last few months, been working with the Primary Health Network in the Central Coast and the Sunshine Coast of Queensland, Rocky, Bundy, Sunshine Coast, and so they have been doing this in their organisations as well. They have a goal. But instead of just saying to everybody individually as a staff member, right, okay, we're really concentrating on moisturising your skin twice a day, men too, as well as women, this month. They would have an afternoon tea, hopefully wine and cheese night, or whatever you can arrange in your own organisation. Bring people along after work when people, relatives, etc. of the older folk can come in and drop in too, or younger people who are working can drop in on their way home from work. And somebody, often an invited speaker would get up, talk about the evidence on the topic of the month, and then there's a big question session. We often had industry people there so they could directly ask the industry representatives, why is this dressing, $10 per square inch, and what benefit does it give to me? It just meant that all those relatives and those people, consumers making decisions, were able to ask more than one person. It wasn't just their registered nurse or the GP saying, you really should be paying for that on your leg to heal you better. They heard it from somewhere else. They heard an evidence and they got given a brochure which had a reference from somewhere else, and they realised that we weren't just saying it out of our own head, that there was some good, strong research behind it, and people were doing it for a reason. So I found that very important. So just very quickly, a reminder, evidence-based practice. I always put this up here because I think people forget that what we're talking about today is what the latest research would show, or what the latest evidence-based recommendation documents have said. But of course that's only 1/3 of evidence-based practice. And we must never remember, of course, that we have to look at the context and what skills you might have, and of course our patient likes and dislikes. And of course every patient just clinically is also incredibly individual, aren't they? So 99% of the population might respond to this treatment, but it's always the 1% that you walk into your surgery maybe who doesn't respond. So we always have to remember there's always individual variation. Where is the evidence? I won't for this, but in your resources, and I'll show you later, you'll see there's big lists of great sites to go for evidence on skin and wound care if you're looking for them. And the resources. Now, on your tables and in your black folders in front of you, well, actually I'll start with this. I've already talked about those 8 evidence-based summary. We've got 8 primary areas in this research kit, and they are skin tears, general skin care, pressure injuries, venous leg ulcers, arterial leg ulcers, diabetic foot ulcers, wound bed management itself, and nutrition and wound healing. So they're all colour-coded. Each one of those 8 topics has a colour on them. You will see that there should be one of these books on every table. And in actual fact, the books you have now are like an upside-down book. If you look at both sides, it's like one of those women's weeklies where it's upside down. So one side is your actual CSI guide, and the other side says dressing guide. They used to be 2 separate books, but we've been desperately trying to save costs recently, and we've combined it into the one book. So all the files, this book and the dressing guide file, etc., are actually on one of those DVDs that's also in that folder. I actually couldn't physically carry, nor did I have the resources actually to be able to give you all one of the big books to get here today because we were out of funding. However, all these resources are on your DVD. They can be printed out. There are commercial print files on the DVD as well as local print files. There are also websites that I can give you where they can be downloaded directly from the QUT website site. And at the end, I'll have my email address up there, and we do still have some left that I can post out, but I could not physically bring them all here today. So I've only got one per table at the moment, but if you look at it, just to show you what resources you might find useful and you might not. And we'll just quickly go through the CSI guide. And it's got a bit of an introduction, which I've just told you, so you don't need to look at that. And it's got some 7 steps on how to be a champion for skin integrity. Now, this is particularly in larger organisations, or if you're an educator and you're educating colleagues, and you might decide that you want to start a CSI team in your facility or your organisation, or you might like to be one. And it just gives you a bit of an idea on how you yourself can go through and become a skin integrity. And it goes through the modules on the resources. And it talks about role descriptions here, and again, just gives you a bit of an idea on how you can adapt these. There's role descriptions for an RN, role descriptions for an EN, and all those files are on your DVD, so you might adapt it and make up your own role descriptions for your own organisation. Talks about the multidisciplinary networks and the linked clinicians, because even though I've talked about that, you'll all forget it. I think, when you go home, you'll remember 1% of what I say today, so this is the least effective way of doing anything. And then it describes the resources. And the first thing it describes in there is the education DVD. So you've got 2 DVDs in that black folder. One of them says resources and one says self-education DVD. On the self-education DVD, if you pop it in, and it uses, I think it's Firefox or something that's freely, will work on any computer. That screen on the bottom right-hand corner of that slide there, what will pop up are like 8 modules, education modules. When you enter each one of those education modules, you'll see there's a menu there on the left. You can look at assessment, management, etc. On the right, there's a scroll of pictures, so you can click on the pictures and they'll come up full screen. There's also, depending on the module, a whole range of little short video clips that you can click on and look at. So if you're a visual learner and you want to look at, how to apply different types of compression hosiery or how to use different types of hosiery applicators, how to pack a wound, how to lay a skin tear, all those sort of little things that you need to watch a process of different bandaging techniques. They're little video clips that are down the right-hand side, depending on the module that you're in. So you click on those and they come up and you can watch those. At the end of each module is a little quiz, and it's like a little self-learning quiz. So if you get the question right, it says, woohoo, congratulations, and you move on. If you get the question wrong, it says, oh, sorry, try again, and it gives you the reason. And it gives you the reason you're right too. So it's just a self-learning exercise. And a lot of larger organisations that we've been in have used like the general skincare module and the skin care module as training, as orientation for the new staff, particularly if you're in charge of training ENs, etc. So that's one of the DVDs, these 8 modules. The other DVD just says resources, and it's literally got all the files that are in this kit that you can download. The education DVD I have found in the past, it walks really, really fast. If you've got a secure drive in your workplace, you can copy and burn all those files on that education DVD to your secure drive so that you can always burn more DVDs. Or you can email me, which frequently happens, and I can send you out more. But I've just found that with a lot of them, it's just good before you even show anybody one to back up the files somewhere. If you have a problem, just let me know. The next thing that's in this big book are those 8 evidence summaries that I talked about in the different areas, and I said each area is colour-coded. And on each evidence summary, at the beginning there's a scale saying what the level of evidence is, just to remind ourselves, because you'll probably realise each set of guidelines uses often a different rating system. Most of them would use Roman numerals or ABC. JBI would use an ABC. But because we wanted to have a summary, we had to re-rate everything on the same system. So we've got the system on the front, we've got all the references on the front so that you can go to those websites wherever possible and check that there hasn't been a new one or an update, because this kit is due for an update later this year. So you can go to those references and check it, and then for each summary, it's just got it laid out, like all the resources in this kit, as recommendations for assessment, recommendations for management, and recommendations for prevention, and the level of evidence is beside it. So the summaries are there really for you to look up when you really want to, and you know, you've got the websites of the full guideline if it doesn't really give the bit of information that you're after. What we found was that nobody likes the summaries. It's terribly dry, isn't it? So we thought, well, no, that doesn't work. They don't want that. We had to move on to other things. So as we go through, you'll see that there's a whole range. First of all, there's these tip sheets printed out. These are specifically for older population. They look like this when they're printed out. So they're in the book just so you can see what they look like. Oh, wait a minute. Oh, I've lost my microphone. There you go. These were things that older people asked us for. They're in very big font. They've got ticks, what should I do and what should I not do? If I'm at high risk of skin tears, what should I do to help my risk decrease and what should I not do? When we started this project, it started out in aged care facilities, so they would put them on their locker, and if they had a different staff member each night, you know, they were able to say, this is what I'm supposed to have done. Carers, family really liked them because there was something they could do. All of a sudden, everybody for Christmas got given, you know, limb protectors and moisturiser. So it's you know, something that they could do to help themselves. There's some tips for compression hosiery. So there's a range of those tip sheets there, particularly for older patients. When we get past those, you will see that there's some printouts of the flow charts, and in your black folders you can see you've actually got some decent size flow charts there. So they're meant for us. When we started, what we found was that we did some brochures, and the nurses liked the brochures, the family liked some brochures and tip sheets. The GPs hated the brochures and the evidence summaries, and so what they asked for were flow charts, and they loved them, so they would put them on the wall because they can stick them on a wall somewhere. So, but you know, everybody likes things in different formats, and that's what we tried to do, was put the same evidence in a number of different formats, and it's literally got everything that's in that guideline in the same format under assessment, management and prevention, and it usually has those flow charts have got a little bit of extra information on it, like the classification system for skin tears or pressure injuries, or the characteristics of a venous leg ulcer or an arterial leg ulcer, etc., or risk factors, and the references are on those. But they were meant to be printed out at least the size that are in your black folder now. The next thing that's in this folder is literally some printed out brochures for both health professionals. We've got one set for health professionals and the other set are for patients and family. So this is what it's meant to be, just a 3-fold brochure. Would look like that. I find that people much prefer this if they're looking for evidence quickly. This is just a summary of the evidence summary, but in dot point form. So something that can be handed around. We've done the same for clients, except theirs, you'll notice, are in much, much bigger size font. And they've also asked if they like to see the ticks and the crosses. So I found the nurses hated the ticks and the crosses, but the patients really liked them. So that was meant for them. The other resources in this kit really are just extra things that you might use and you might not. So you might get around to it and you might not. There's information links, there's the website links, there's an audit form if you're so that you can check. Particularly if you're working in larger organisations, but you can do an audit on a single patient. You can do it on just a particular type of wounds, and then you just tick to see what measures are in place, and then you check it against the guidelines, and a whole range of tools, and the DVDs. Good-o. When you turn it upside down, you've got this wound dressing guide, because the first thing everybody asks is, what do we put on it? But sadly, there's actually not a great deal of evidence, as you will see shortly, on what to put on it. And there have been many systematic reviews done which show that it doesn't really make an incredible amount of difference what you put on a wound. Now, I know we've probably got some company people here. But there's a few exceptions for that, but there's 3 main exceptions, so they're really easy to remember because there's only 3. First exception is cover the wound. So back to the sunlight question. There is a significant body of evidence in many large randomised controlled trials that's happened since the 1960s, which would say that if a wound is covered, there are lower rates of infection and it will heal faster. We still don't believe it. I still have patients there who would like to put it in the sun. Vitamin D is great. Put the rest of the skin in the sun. but not the little bit with a wound on it. Cover it if you can. And so in those client brochures, although there were slightly different topics for the health professionals and the clients, we did actually do a wound care one for the clients because I just wanted to put that point in, don't put your wound out in the sun to dry. Cover your wound. Our next body of evidence is, you probably realise there's a growing body of evidence which will support that if the wound has clinical signs of infection that you would put an antimicrobial dressing on. There isn't very strong evidence to support any one particular antimicrobial over another. The best one we've got, it's actually a lovely Australian trial, Carolyn Carville. Has anybody been to any of her talks? A fantastic lady who compared randomised silver and iodine. And the iodine won out, but only just. Wasn't a big difference. So those good old iodine. So that's put an antimicrobial on. You need to only put an antimicrobial on though for 2 or 3 weeks and stop and reevaluate. So it really needs to be reevaluated after 2 weeks because it should have done its job by then. And if it hasn't done its job by then you really need to think about why. Have you got so much slough on that wound that needs debriding that that poor old antimicrobial can't even get to the healthy bit underneath? So have it looked at by an expert maybe and think about why it hasn't worked. Because the longer you leave it on, unfortunately nearly every antimicrobial, and I know there's a few wonderful new ones always coming out, is very toxic to new healing cells. So great to kill off the infection, but it's toxic to new healing cells. The third body of evidence that I'd ask you to think about when you're choosing a dressing is that there are a number of systematic reviews which would say that modern dressings are better than gauze. Anything's better than gauze, really. So if you do have a wound, it's not a person who's going to heal in the blink of an eye, a young person with one tiny little stitch on, it's an older person with perhaps a few risk factors. Try not to use gauze. However, those 3 bits of evidence really don't guide you terribly well. So we've written a wound healing guide to add on top of that, using consensus recommendations to our best of our knowledge. And the way it's set out is it's set out within generic groups of dressings. So there's alginates, hydrocolloids, foams, etc. You'll see, and under each generic type, you'll see there's headings of saying, well, what is this dressing made of? What's it used for? What sorts of wounds should I use it for? What sorts of wounds should I not use it for? There's generally some myths and tips, etc. It gives you the brand names of, so all the companies that would produce those alginates. And I would grant you this book is 2 years old now, and we're hoping to update it. Yes? Yeah, you can. I've still got a few left at the moment, like I say, so I'm trying to get them out of my office. And if we should run out, you can. Unfortunately, the Department of Health, we were funded by the Department of Health and Ageing, then we went through about 6 changes of government, and it's been moved to another section of the Department of Health who are just trying to get their head around it still, and so they haven't given me the money for the update yet. So to print it ourselves, it actually costs me about $70 or $80. So for a full kit, yes, I would charge that much. I don't know whether you might get a better deal, using the files and printing it from a commercial printer. I would certainly go and look at it because, I have to use QT printing. They're not known for cost cutting. So, but that's how much a full kit would be, which would include everything. So, and it's got the advantages and disadvantages of every wound type. So you can go through there, and once we've done, an evidence-based assessment of your wound, and you know what sort of wound you've got, you've got a really weepy wound and it's not infected, etc. You can actually go and look at some of the properties of the dressings and find one that's very absorbent, that's not an antimicrobial, or you can choose an antimicrobial absorbent because all those properties are listed under the types of wounds. Does that make sense? Good. I hope you find it useful. Our original model we actually trialled in 7 aged care facilities. So we actually did a skin audit so that we get some feedback, firstly so that each facility could work out what was the biggest problem in those facilities and target their interventions to those. And secondly, so that we could justify that the model works, of course. And what we found was after 6 months, you can see our incidence of pressure ulcers were halved. There was a small drop in skin tears, but not many, but what we found was that our incidence of category 3 skin tears and category 2 had dropped by 60%, really gone down. So, and particularly the areas that had concentrated on either skin tears or pressure injuries had very, very good results. And it was just lovely to get the feedback and say, well, a few small changes in prevention really can make a difference. Based on the results of those, so that was in 1,400 residents we had. Based on the results of that, we were funded to be able to update the kit in 2014 and run a series of workshops around the country, which we did until last year, and we're just moving into, and then I was asked by the Primary Health Network up the Sunshine Coast if they would like some more workshops. So we're still running and still trying to keep the program going. So I'm just very, very quickly going to put up here some evidence, recommendations for the major types of wounds. However, stop me at any stage. I'm going to flow through it all because you won't remember every recommendation, and it's all in your book. And it's all in your brochures anyway, in a very short dot form, so it's easy there. But looking at wound bed management ourselves, it's recommended that we do a very thorough assessment because so many factors impact on our immune system, and everything that impacts on our immune system impacts on the wound healing process. So missing an assessment of pain or nutrition, etc., might really be the key on why somebody's not responding to your treatment plan that you have done. As a matter of fact, I'm currently working on a couple of research projects looking at pain in particular, and it looks like, it's probably, I think, a lot more important than we think, in that it's not associated with the severity of the wound or the severity of the underlying chronic disease. People experience pain very differently, but people with high levels of pain, it can be shown, it predicts whether they're going to heal 6 months later. And the biologists that I work with would say that's because it kicks off some funny thing, which eventually impacts on our immune system and slows down the healing process. So I think pain management, is really important and something we should be looking at. So classify our wound, assess and document signs of infection, and if you've got a patient who is at high risk of infection, a high risk foot or something, remember to document if you do not have signs of infection, because often their feet will go up in 18 hours overnight. And they'll be looking to see when did this infection start to try and judge how severe it is. And of course, reassess and document progress in healing regularly. We all know that. We all know signs of a healthy wound. Looks lovely and pink. It's not smelly, getting better. No pain. Now, I've taken that from a consensus statement document, but I would say everybody has a little pain, but not an abnormal amount of pain, as opposed to a wound that does not look good. And there are our classic signs, of course, of severe infection where we've got large amounts of exudate, increasing pain, the patient's starting to get systemic symptoms, and you've got really an acute situation there that needs immediate treatment. And one of those references in there you'll see has got, there are some consensus statements on management of chronic wounds where you look at the less severe signs of infection, what we can't always see. And they're just things like, your abnormal granulation tissue, where you've got that really bright red friable granulation tissue, where it's just not responding to treatment for no known reason that you can see. Or you notice the edges start to roll. An amazing number of these chronic leg ulcers will end up malignant, so you may need a biopsy. So it's a really good document. If anybody's interested, I can point it out to you in the... I'm just trying to think, it's one of the Wounds International ones, I think, when the website's there, just on signs of infection in chronic wounds. So assessment of size, I'm sure we're used to doing that. Do you trace and photograph or both? Photograph's usually easier than tracing, isn't it? Although I do think tracing is a lot more accurate if you've got a particularly difficult patient. So if you photograph, do you use a protocol, a photography protocol? There are quite a few around. They're really good if you do look after chronic wounds that take months to heal, as opposed to a couple of weeks. There's some great photography protocols so that you're always photographing, from the same side, same angle, same distance from the wound, light, etc. Just to remind you to keep all those things consistent so that people can actually see progress between photos. And if you email me, I can send you those too. So there's some great tables here. Again, as we are on a fairly tight timeline today, I wasn't able to print out PowerPoints. However, if you email me at the end of today, I can send you these PowerPoints. If you are training staff, I have a whole range of PowerPoints because we've been running full day trainer workshops where we do, would hope that you would go back to your colleagues, or if you're an educator, and also be able to give a talk to the GPs, a toolbox talk to the GPs, and just raise their awareness of what the evidence-based recommendations are on a particular topic. So I can send you that. I have a range of PowerPoints there I can send you, and they include some of these tables. Just looking at wound edges, we know that the shallow wounds are more likely to be venous, whereas a punched out wound is more likely to have arterial involvement. Undermining in both diabetic feet and in pressure injuries, and a good old callus on your diabetic foot. And I usually say Queensland, of course, is the king of the SCCs, but I'm not in Queensland, so maybe you have less here. Site, sometimes just looking at the site and the depth, etc., can give you an idea of the cause of that wound so that you can guide you when you're making a diagnosis. Diagnosing tissue, looking at the surrounding skin. So this is all about doing a comprehensive assessment. And you'll see with the health professional brochures, there's a whole brochure there on wound assessment because we were asked to do it, and people just wanted a few tips on how they might have their own wound assessment documentation. Because we don't have a consistent, wound assessment documentation in Australia, and I find every single organisation has their own assessment form. So in that brochure are the things that are recommended to be included. And more differential diagnoses there on your arterial and your venous and your diabetic foot ulcers on characteristics. And of course these days, as we're all getting an older population, and unfortunately increasing still with peripheral arterial disease, we often have patients with the lot, don't we? All. So mixed ulcers, I think, is a great topic for explanation when you've got both arterial and venous disease, and trying to work out an adequate treatment plan for those is really interesting. Wound shape, margins, surrounding skin, and the different types of pain. So what do the actual evidence-based guidelines say about wound management? They say that we should clean them, that if you've got potable tap water, which most of us would have, it's perfectly acceptable. And that we should remove any dead or devitalised tissue, your slough or your necrotic. And I mean, if that's actually difficult, and you've got somebody whose slough isn't relying on just breaking down with your normal mechanical debridement or your dressings to help break it down, then this is where you need your network to call in an expert who's got the skills in sharp debridement. So dressing should maintain a moist wound healing environment, but remember that you also need to contain and absorb the moisture if you've got a weepy wound, because you don't want to damage the surrounding skin. So I always say, and I can't help it because it ruins the ad, but it's like the cereal advertisement, you can't have it too wet and you can't have it too dry. Not too wet, not too dry, it's got to be just right. So you've got to really balance your moisture. Most people would have heard of the time concept of wound healing. Yep, so if you're looking at T, you're looking at tissue type. So if you're trying to choose a dressing, you know what sort of tissue you've got, so you know whether it needs debriding, and you know what sort of, you might have to choose a dressing that's going to help with autolytic debridement. I, for infections, you've assessed for signs of infection, so you know whether to put on an antimicrobial dressing or not. M for moisture, if you've got a weepy wound, a dry wound, or was the dressing you just took off sticking, or was it, not absorbent enough? So you know, again, another point to go to your dressing guide. And E, have a look at your edge and see whether you've got a wound that might need further intervention and whether it's healing. So all those things, when you've done that assessment and you've got them in your head, then you can go to your dressing guide and choose a dressing that will address all those characteristics. We know that actually the longer we can leave it there, if you do not have a high-risk patient and they do not have an infected wound, if you can choose a dressing that will last a few days, it will heal faster. Because every time we pull it off and wipe something over it, we're killing off all our healing cells, whereas the body heals it much better. So if you can, and that's another reason we did all those client brochures, to sort of have some backup. It's best not to change it every day, or twice a day, or 3 times a day, because you're just causing more trauma than you necessarily do. And of course, the more non-adherent the dressing, the better. And of course, as we said, if we're looking at signs of infection, we need to choose an antimicrobial. So I'm not going to go through these, time's coming short, but here's some summaries, but done in a different way. In your dressing folder, it's done by dressing, and it's got all this same fish in, and I've just grouped them here on these PowerPoint slides under the type of wound that you're looking at. Remember, if you do have necrotic tissue and you have a big dry blob of eschar there, don't try and soak it off without getting an expert opinion. So, because you really don't know what's underneath it and you don't know if the circulation's adequate. So once you've got somebody to assess it, assess the circulation, then you might be able to get someone in to do some sharp debridement. Sloughy wounds, so again, we know we've got slough, but we still have to assess whether it's a very dry wound or a weepy wound before we would choose a dressing. And you can see there's some suggestions there. If we've got a nice granulating wound, then really it's just a matter of choosing a dressing that's going to absorb the exudate and keep it protected. Same with one that's nearly healed. Infected ones, antimicrobials. And we move on to skin tears. Are you all still awake?
Yes.
Good. So a quick recommendations, and you look at that and you see the level of evidence there says expert opinion. Not enough research in this area. Anybody who wants to do some research, I'm very happy to oblige. So, or get involved. Funnily enough, it says use a recognised, perform a risk assessment, but there are no validated risk assessment tools for skin tears. And so I find again, everybody tends to develop their own, going on the known risk factors from the literature. Cleanse your wound. One thing I didn't show you before that I should have shown you. In the main book, there's at one page there's a thing that's called a skin tear management kit. And this has probably been the most used thing, actually, for all our things. So the skin tear management kit, and it's on your DVD, has got an assessment tool that people can use for the documentation. So it's got the STAR system. Does everybody use the STAR system to classify skin tears? Up the top to remind you, some space there to write down when it happened, you know, what you did with it, etc. On the page behind that, it's got what risk factors cause this skin tear that you're looking at today. So you ticket them so that you could then perform your prevention care plan to address those particular factors. This is just a sticker for electronic systems. On the back of that is a little flow chart, emergency management of a skin tear. So it just talks about cleansing, you know, clearing out your blood clot, etc., whatever. Realigning your flap, and on that, one of those, the skin tear module, it's got an example little video of rolling a skin flap with a wet cotton bud. Is that what you call them down here? Etc. Drying it off, and the best recommendations, you know, putting on a nice non-adhesive soft silicone dressing, putting an arrow and a date on the dressing and the direction of the flap so that you don't rip it off when you're taking the dressing off. So it's like an emergency flow chart, and a lot of people have printed this out and stuck it up on a wall beside their skin. It's also on the big skin tear A3, but that's got a lot more information on it. So, yes.
On using steri-strips as well to anchor that skin?
Yes, well, steri-strips aren't mentioned here. But if you are going to use them, but nobody's ever done a randomised trial of them either. Steri-strips always cause a problem when people pull them off because they cause trauma. So if you're going to put them on, I wouldn't put them on anybody who has a cognitive issue because they're going to pick at them and pull them off and cause more trauma. So that's one issue. Actually, people with cognitive problems are a problem all on their own. But anyway, they're with wound dressing. If you're going to put them on, leave them on and make sure that the family and the patient knows not to ever take it off. Wait till they rot off. So it's not advised, it's not in the latest consensus document to use it. They would advise to use a non-adherent soft silicone dressing, but we all know they're expensive. And so, you know, but if you're going to do it, yeah, it's just, and always leave a gap between your steri-strips so a bit of exudate can come out. So I know a lot of people have actually, in the larger organisations, had a skin tear emergency kit. They got a fishing tackle box. It was a skin tear kit. In the box was a limited supply of those lovely, nice, expensive dressings. You know, some saline to flood the wound, some cotton buds to roll a flap, etc., and something to dry it with, and a pen, etc., and this paperwork. So they've got their sheet. And I must say this is often, you know, where you might have an enrolled nurse or even an AIN who is in charge of providing immediate care of a skin tear rather than a registered nurse. But they can write it down and then they've got the documentation filled out so that they can leave that there for the next person that comes along, and the next person doesn't really have to rip it off then and have a look at it. So that has been very useful. When you're looking at preventing skin tears, we know that we need to be gentle. We should avoid soap, moisturising twice a day. I've got a picture over the level of evidence there, but it's actually only in this kit will only have an expert opinion level of evidence, but again there has been a really large study done of that where people compared once a day moisturising after their bath to twice a day in aged care residents, and they halved the incidence of skin tears. Such a simple thing that everybody can do. In our first project, we actually had to do a bit of a campaign for the men where my finance fellow is a big 6.5 foot tall, manly looking man. And I said, Bob, you've got to write a story for me with photos, etc., of you moisturising the skin. Well, he was horrified, but he did it, and he smiled. And we put it out in newsletters, you know, like your organisation newsletters, say how important it is for everybody to moisturise, not just women.
I went to a dermatologist in a skin hospital, and all of the specialists in one meeting said the problem with most of the aged care is they're not drinking water. This is why there's a problem, and they should. They did a trial in one of the Melbourne places, and everyone was given 6 glasses of water a day, and all their skins were better.
They were better. Yes, I've seen a few on that, and that's a contributing factor, and it's on the risk things. But I must say that this other study, where they had much larger, it was done in Western Australia with 14 aged care facilities, so there were thousands of people involved. Even controlling for the amount of water, moisturising twice a day still really made a difference. So, yes.
In that study, did you check between the different products of skin moisturisers?
No, I didn't do that study. That study was done by Carolyn Carville. No, they did not. They said one group just whatever they were doing now. So you can imagine over like so many facilities, there was a lot of things. So that most of them were being moisturised once a day after the shower with whatever was in the room. The other one, the intervention group, like I can send you the study if you're interested afterwards. The intervention group were one particular type of moisturiser. So you can't compare it because you don't really know whether it was. I just can't remember what it was. You know, one of the nicer ones, or something that was pH neutral, and I should remember, but I can't. Yes, there actually hasn't been much research in the type of moisturiser, and nobody's really found much difference except. If you do have somebody with really, really dry skin, it's generally recommended to use an oil-based moisturiser rather than a water-based type of cream. Saying that, most people don't like the oil-based ones, so I just find most people are happy maybe to put the heavier ones on at night and a lighter one on in the morning. But yeah, it's waiting for some more research. They halve the incidence of skin tears, yeah. Yes, I've got a copy of the article and I can email it to you. It was obviously a high-risk population. We're talking about aged care residents here, and they've got all those other risk factors for manual handling and that. But still, I think it's a good outcome. Leg and foot ulcers. So we all know that anybody walks in, particularly with a leg ulcer, that we need to assess their circulation because, as we know, our primary recommendation for venous leg ulcers is compression therapy. And we can't apply compression unless we've got a pretty good idea of what their arterial circulation is. So if you don't do your own ABPIs, then it's good to have a network where you can call in somebody who can do an ABPI for you. Or maybe more in your type of organisations, you would refer them off for a duplex, I'm not sure. Whatever works. So we know that if they've got a high ABPI, we need to send them off for further investigation. Of course, if they're low, we can't put on high levels of compression. There's a whole range of risk factors there, and these are on your flow charts on when you really need to refer to a specialist. When you look at the wound care recommendations, you can see they're exactly the same as our general wound bed recommendations. So there's no point going through that, particularly for venous leg ulcers. We know that we need to undertake a Doppler whenever we're starting compression or we're changing the type, etc. After they heal, before you might apply a hosiery on them and regularly. We know that high-level compression is recommended and a strong body of evidence of that to heal a venous leg ulcer. Unfortunately, it's quite difficult sometimes to have the skills to apply high-level compression systems. So again, this is where you might need your network where you've got experts to come in and try and get adequate compression on those patients. We know that there's in this group, actually, unfortunately, a whole lot of those extra therapies there isn't any evidence to support that they're of any use at all. Amazingly enough, there's even evidence from the Egyptian times that in those days they used to squeeze the leg and put zinc on venous leg ulcers. guess what? We haven't changed in 3,000 years. So, yeah, we're still going. Compression. After healing, of course, we need to move from a high-level multi-layered compression system down into compression hosiery. Even at this level, the ones in class 1 hosiery, although they might have slightly better outcomes than no hosiery at all, it's not much. They really need to be in a class 2 for it to be very effective, so 20 millimetres and above. So they really need to be fitted by somebody who's got experience in fitting the right stocking and ordering particular types. If you've got funny shaped legs, you might have to get them individually made to fit that leg. Okay, other recommended strategies, good old leg elevation and exercise, lower limb exercise, although there's not much research to support it now, the little bit there is there would say it looks like it's quite supportive. So, you know, if you do have a patient who just flat out refuses to wear compression, then I would send them to a physio and get them some kind of leg elevation and exercise program underway to try and improve their exercise. And don't forget, this group also respond if you send them, if they're able to, well enough, to surgery. So send them to a vascular surgeon and see if they can get their veins done. Arterial leg ulcers, so some signs and symptoms there. I will quickly run through this, and they're on your chart. Unfortunately, we don't have much evidence base to heal this population. This is a mob that really need to be referred to a vascular surgeon, preferably sooner than later. So if you do have signs of peripheral arterial disease in their 60s or 70s, I'd be thinking about referring them to a vascular surgeon before they get to the stage where they've got a wound that's not going to heal and they end up losing their leg. Risk factors, of course, this is where you are in a great, place to be able to introduce risk factors early. It's not much good me telling them in a nursing home that I need to start losing weight and stopping smoking, but you are in the best place to reduce all those well-known risk factors for arterial disease when they're young. Interesting, very strong exercise there. You see level 1 exercise for calf muscle exercises. And we've introduced this even in nursing homes. If they can't do it themselves, passive exercise is better than nothing. If they can sit in a wheelchair, they can do heel raises on there. And a physio will give you a little set of exercises to do it. And simple heel raises actually really do get that calf pump going and help with both venous return and arterial flow. So a simple thing that we can all do. Try and get these people to always keep their legs warm so that when they bump it, they don't break down, so they can cover them if at all possible. And of course, protection is much better than the cure. And the same thing goes with diabetic feet. Teach them how anybody with peripheral arterial disease, how to check their feet and their legs. If they start looking at, they can see signs of redness from where a shoe is rubbing or something, they really need to attend to it now and get them off to a podiatrist before they cause damage. Same with our diabetic feet, and I think people are actually more familiar with this than other types of leg ulcers. So do you all have access to a high-risk foot clinic for anybody? Some of you? Some, and not. So there's some little modules in that module lock videos on how to do a daily foot inspection, etc., so that you can teach your patients and your clients how to do that. This is a very high-risk population, and interestingly enough, there's strong evidence there. So if you actually haven't got signs of healing after 2 weeks of offloading and treatment, they need to be referred off to a specialist. So this is where your careful measurement, because sometimes it's difficult to tell from a photo in 2 weeks, so careful measurement, and you might need a volume measurement as well, or a probe if you've got tracking there every time they come in, so you can see whether they've had some improvement or whether they actually really need to be off to a specialist as soon as possible. A multi-D team is really important in care of diabetic feet, if at all possible, and we can do a lot these days with teleconferencing, which is great. And our first line of treatment for all diabetic foot ulcers is offloading. And there isn't any evidence on which particular offloading method is any better than another. So I would refer them on to whoever your specialist is in that area and get them to get that pressure off. And there's some prevention ones there. Pressure injuries I won't go into much because I think that probably it's not a population you would see a lot of. However, the information is all in your kit. Staging systems there. There's a website in your kit which would take you to the new international pressure ulcer guidelines, which were put out 2014, which are fantastic. They've got whole sections on the bariatric patient, on the paediatric patient, on a whole range of difficult populations that we haven't really addressed before in guidelines. So it's certainly worth having a look at. So I'll just quickly go through those. Okay, so we've gone to that. You've looked at that evidence and you've decided, and you've got this patient who said, right, I want to change. It's not always that simple, is it? I've got a whole range of ideas here on change, and I'll put up there just a very short slide on barriers to change. So, you know, there are things that just to be aware of, to think about, and this is why we've done our teams in the first place, because usually one person deciding to make a change, deciding that if they might have 3 people with venous leg ulcers, so they decided, right, I'm going to do something about this. These people haven't healed in 12 weeks, that's my danger sign. I'm going to call in an expert, see if they need to be in a different compression system, if they need a different applicator. Don't forget the different types of applicators for your hosiery, so that they can actually get them on. And I'm going to do all this, but one person alone usually doesn't get anywhere without putting all those other strategies in place, and that's like raising awareness, having everybody around you who's in the decision team aware that there is an issue, that we should be doing better. So leaving some of the brochures around, etc., writing stories and newsletters, having meetings, bringing it up, setting goals as a team and as multi-level teams so that everybody's on the same side, etc., are a whole range of ways that you can address some of these issues. And, you know, facilitators for change there, when the need for change is high, and sometimes you've got to be the one to actually bring out that need and be the champion and let people know there is a need, that you're dissatisfied and that there is an alternative. So communication is a great thing, and I have a whole range of other templates that I've used if people are interested on action plan templates, how to set down things down to goals, dates, small goals. Everything starts with a small step. Communication plans, because often when you change one thing, a whole range of people need to know about it. The doctors, the family, all their specialists, etc. It doesn't happen in isolation. And actually putting it down in a plan and realising that you've got to tell these 15 people before you even start saves a lot of angst later on when somebody realises that, no, I didn't hear about this and I don't want to be involved, and etc. So there's a whole range of templates out there that are really useful if you're interested in getting some of those. Change starts with a vision, and I think we're all pretty well aware of that. And this is another template I can give you too. So there's a whole other project team in this team who actually just focused on change management, and they developed a toolkit themselves, which I also have a link to if you're interested, where they're based on these 8 steps, and it just gives you, if you want to make one change in your organisation, it gives you these 8 steps to sort of go through and get it in. And you know, importantly at the end there, to make change stick. So you really need to get it into protocol and policy. That might be easy if you're working in a small clinic. I think I found the smaller the organisation, the easier it is. That's great. But if you are working in one of the organisations we worked with, you know, had 700 residents. So getting things changed in that organisation was a slow process. 3 phases, and it's always good to look at your colleagues and work out which phase of change they're in. You might have raised this at a meeting and everybody agreed, but really nobody ever really agrees at the same time, do they? They might just not say anything, but they don't always agree. So you'll find that there's people in different stages, you know. They just don't want to change. None of us like to change, ever. You know, or they think, oh, well, it might be a good idea, but I've no idea what my role is and how to get it, until finally somebody says, and perhaps get some feedback and says, right, this is the way to do it, how are we going to move on? And you finally see some progress. But usually when you're looking at your team and your workplace, there's usually somebody in every one of those stages at the same time. So communication is the key, and acting as a champion and communicating all these things is so, so important. Right. Now, we're just going to do a quick things. We have 10 minutes left to do some quick case study work and find things. So what I would like you to do, in a minute I'm going to put a picture on your table, one for each table, and you can pretend you're all a surgery and this patient with this wound has just walked in with that wound. I apologise, a picture of a wound isn't much of a patient, I know. However, I know every one of those patients attached to these pictures. And so I'll be walking around and you can ask me questions about that patient. And I will want you to have a look in your book or your flow charts and answer some questions that I'll put up in a minute, so that you can actually get used to finding where the information is, so that hopefully when you go home, this doesn't end up in a corner of your bedroom and you say, well, I really enjoyed that, I think this will be useful and I will take it to work next week. And 2 weeks later you say, oh yeah, I've forgotten that, I must remember to take that to work. And then 10 years when you move house, you find it in the corner of your bedroom and you say, oh yeah, That would have been useful, but I never really took the first step. So sometimes, if you know where to look quickly, and taking the first step is often the hardest to get things into use. So we're going to have a quick practice run. If you looked at that foot, what sort of ulcer would that be? So the dead giveaway there is all that callus around there, and one of the main points you'd be teaching your patients when they're doing their self-care every day, if they're starting to develop callus, they're not wearing the right shoes, or they're not wearing shoes at all. So what stage is this pressure ulcer? Oh, blimey, I keep pulling this off. It's reddened, doesn't blanch. Yep, stage 1. So I know you're not probably used to a lot of pressure areas, but do you know how long you'd normally leave it? If you go in, you find somebody who looks like they might have a stage 1 pressure area, you really need to take the pressure off and then come back and assess it. And so most people would go away for 30, 60 minutes, come back. If you still have non-blanchable redness there on that area after taking the pressure off for 30 minutes, then you have a stage 1 pressure injury and it needs to be documented. How about this foot? Yes, well done. Doesn't it look disgusting? Poor thing. So we've got that shiny coal skin. Sometimes they're almost purple when they hang their feet down. They're complaining of cramps, etc. They've got to sleep with their feet down, usually over the pressure points. And the tissue doesn't look very healthy. And of course, horrible looking toenails, thick toenails. Pressure ulcer? Yep, somebody said 2 there. So it's just a partial skin loss. How about this leg? Yep, lovely champagne bottle leg there. Shallow ulcer. Now, I know it's not a good picture that, but that's actually exposed tendon there. Yes, 4. So if we've got exposed bone or tendon, it's a stage 4. How about this one? Yep. It's kind of, this one, going on general consensus, we would probably more call a suspected deep tissue injury because I can sort of see that we've got the bruising underneath. Okay, so here are your questions. Let me give you all a patient. Oh, and I've got some butcher paper here, so pick somebody to write some quick answers to. There you go. And we could just find your primary task for what sort of wound is this? Oh, there you go. That is a bottom, in case you're wondering. Yes, 9 minutes time. Right, okay. Okay. What have I got there? There you go. Has everybody got a wound? You can write it down if you like, or if you want to just write it on paper, that's fine. We're short of time. Oh, okay, thanks. Oh, you're right, they've got to do the work now. So I don't want you to write down what you know. I all know that you could do a care plan for that old wound yourselves. I want you to find the answers from your kit, from your flow charts, from the evidence. It's not always the same. So you should all be able to pull out one of those big flow charts, or one of those. Yep.
So we're going
So, you know,
with this management.
So yes.
And I think this is an infected venous leg ulcer, but I'm
Perfect. And so all you need to know out of that is that the venous leg ulcer resources are green. And there's your green flow chart. Okay, what have you got here, guys? Oh, yes. So with your flow chart, you'll notice the skin tear flow chart is pink. Yes, all brochures, pink. Yep. Oh, you've got an easy one. Yes, orange. Yep. What have you got here, guys? Have I already asked you? Oh, yes. So all you need to know, red. Right.
and what medications she was on.
Now, you worked, yes, that's right. Oh, you worked it out. Good-o. So I was just, see, I'll give you easy ones, yes. We don't get many at that stage in.
I guess it's helpful for us because we were just saying that we don't really see many in general
I know,
practice.
I know. But I think the whole idea of this kit is for people who do not see things that are unusual, and it's just to give you, if you are faced with something you're not used to, just to know where the evidence is and to have some resources and go for it.
Some just go to nursing homes and they go and send a window.
They do.
What to do with it.
Oh yeah, they do. See, they could take the flow chart with them. Or the DVD. That takes too hard though. You've got to have something quick and easy. Yeah. It's a funny thing because in that first one, you know, we asked them to come and do workshops at the nursing homes, and of course they wouldn't. Well, they didn't have the time. So I went out and said, "Oh, are you happy for me to turn up at lunchtime?" So they were. So I went out and turned up at lunchtime to quite a few of the surgeries actually, and you know, sometimes you got them and sometimes you didn't. But yeah, that's when they just sort of, flow chart, right. Yep, right.
It's always a matter of matching care with money.
Oh,
too.
yes. Well,
and the same in nursing
right.
homes, no different to general practice.
No, it's the same issue actually, yes.
That
And that's another whole...
constant irrigation thing that they
look, you know, that's actually the early... No, well, there isn't any strong evidence on it yet, but only because it's new. But the last study I saw looks really good. Yes, it looks good. And
looks good. The
yes,
evidence is
the evidence
good,
looks
because you
good.
don't know whether it's still in the cell from the
No.
suppliers, right?
No, I know, but actually that does look good. So yeah,
Okay.
I would use it. Yeah,
You
yeah,
use it,
yeah,
folded it in, and then went.
We used it. We
ask
were in
around
clinic
before
at
I
the
use
uni, you know, for teaching, and which is run by nurses clinics, but and they use it. Yeah.
Oh, they use it. Okay.
And so I would trust them. They're pretty good, but you can't trust them. But I did see a couple of studies, and it looked hopeful. So I thought, it looks like it actually does. You know, it is a really good surfactant to be able to clean up the wound. Because the reality is, well, if you've been to one of Jan Rice's days, I mean, it's just that we're not very good at cleaning up that wound. Everybody's too gentle. You know?
Yeah, and
she'd be
put it clean enough.
you've got to clean it up.
Doctors go, Deb.
Yes.
Done.
Whereas that, I think, actually helps because I think it does
you've got
help
to wash it.
break down. Yes,
Irrigation.
that's right. Yeah, and you do really have to.
You're only like your 9 minutes to quarter to.
Yeah, no, which is good actually, because that gives them a couple more. I'll give them 3 more minutes, and at quarter two we'll just run through it. It's just really so that they get an idea. Yeah, I know.
You need a 3-hour session.
90
You really
minutes.
need to ask for a 3-hour
Yes.
workshop.
It was just one of those last minute things because I was working with Jodie, she must have known somebody on the conference committee, Jodie. She said, I said, my friends, she said, why don't you come down and do a workshop because we're going to do a paper on the project that we did with them. So I emailed me. I said, oh yeah, they're happy, but then I didn't think to look about. Actually, it didn't even occur to me to ask, how much time slot is all this stuff.
Because you could easily do 3-hour time slot maybe next year.
Yeah, maybe. Be good, especially if we have the new kits ready. Yep. That'd be nice. It would be nice, yes. Okay. You're all organised by the look of it. Remember, you've only got 5 minutes in your lunch break to do this patient. Okay, I'm going to move on. I'm sorry, we are very time constrained today. It's a shame because I love to see all the talking. So no, you're right. I will move on, but you get the idea. And these are the sort of activities, if you are an educator, that you could run quite easily in your own, a quick, and you all found the right colour wound. So that's the one thing I want you to remember today is what colour are the resources for your wound. So has somebody got this foot? I think we do. Do you have this foot? Yes, we do. Okay. Yes. Everybody listening? Right, so what did you diagnose the ulcer as? Okay, so that's pretty easy and we can all tell. And so if you look at our assessment, how would you manage it? What would be your first thing you'd do to manage this foot? Management. Did you get to management? Yeah, good. Yep, cleaned it.
Yeah, we're going to clean it. Yep.
Debride. Offload. Tick. Okay. Yes. Wonderful. And what would you do to prevent another one after you've healed it?
If it bred another one.
How would you prevent another one? Yeah, sorry.
Good shoes.
Good-o. Well done. So if anybody's looking for diabetic foot ulcer resources in your kit, they're orange. Somebody's got this foot? Right, so what did you diagnose this one as? Yep, arterial leg ulcer. And how would you manage this one, do you think? Yeah. No, you're right. A management? Yep. Did a screen? Yep. Yep.
Any other sort of psychosocial issues that might go around. And then just assessing in relation to the wound chart as to what we have there, so that we thought we probably needed an antimicrobial.
Okay.
Depending on.
Do you all agree with that? No, sorry. So we're going to use an antimicrobial dressing on this. How else would we manage it?
Risk factors as well too.
Yep. Sorry? Exercise. Calf, yes. So foot and ankle exercise and calf muscle exercise would be really good for this one. How would we prevent another one?
Obviously smoking, lifestyle,
Protection, yep. Exercise. And a vascular surgeon. Yes, this person definitely needs referral to a vascular surgeon. You can actually see on that foot, if there's a scar from another one. So this lady likes nice shoes. And so she really needs to find a podiatrist that sells pretty shoes that she'll be willing to wear. So we sort of have to move sideways sometimes to try and work out how we're going to get prevent the next ulcer. No, I often get that question. It's just the way the photo is. The second toe's lifted up, and that's the second toe that you can see. Sorry. Yeah. Oh, it's possible in the future, but not now. Has somebody got this arm? Good-o. So what did we diagnose this as?
We thought it was a skin tear category 3.
Perfect. Yep, because we've got no flap at all. Okay, and how are we going to treat it?
Management, we're going to clean it.
Yep.
Use the low adherence soft.
Yes.
And overlap it by 2 centimetres.
Yep.
Put a nice frame around it. Date the dressing.
Yep.
We don't need to put arrows on it because there's no flap to
No,
keep it up.
good, that's right.
And protect the limb.
Good-o. And how would you prevent another one?
Moisturise padding perhaps on the chair.
Yeah.
Think about removing how you remove clothing.
Yes. Maybe long sleeves if she's not somebody who normally wears. Lovely. Has anybody got this lady? Just looking at that, what sort of ulcer would you say? Yeah. So you can see the hemosiderin standing on those legs, the scarred, on one of those other legs. If you look closely, you can see some scars from total knees replacements, and often anybody who's had a DVT or a major surgery and perhaps an unrecognised DVT in the past are really high risk of venous leg ulcers. So it gives you a bit of a clue. Anybody got? I don't think anybody's got this one. So this is one of those patients with a large bit of dry eschar that I would not try and attack myself, and I would get a specialist to cut that off. So this is actually a lady who was taken out of a nursing home for a day by relatives. She was cognitively not very well and couldn't tell somebody that her heel was bleeding. She was not in her normal wheelchair, which would have had padded wheelchair plates, and she was in one day. Well, a few hours actually, like 8 hours. The relatives took her out for the day. She kicked her slippers off, so they left them off, and so her heel was resting on. It wasn't a nursing prop wheelchair, her own wheelchair. She left her heel resting. She was obviously a compromised patient, a high risk patient, on a thing, yes, all day. And this is what it looked like the next morning. So it's just a lack of communication because the relatives didn't realise. And the nursing home staff didn't think, perhaps, to warn them. So, it's just lack of... I mean, that actually healed well. It was cut off and it healed well, but it's something that could have been avoided. What would you call this one? Yeah, it is a diabetic foot one. You can see all that dry skin around there. I think somebody's got this one. Right, so what did you diagnose this one as?
A pressure injury.
Yep.
Assess the size, take a photo and check the X-ray.
Yep, what category did you call it? Three, yep. So,
Management, relieve the pressure, give the good
yes.
pain, gentle debridement if necessary, or cleaning it, Solisite gel to the sloughy area, and put a protective dressing on, foam or clean, something like that. Prevention, have a team management plan, educate the staff and carers, avoid pressure, friction.
Yep.
Moisturise BD, watch and protect other areas on the patients, so bone rings, donuts.
Yes.
Reposition regularly and reassess the nutrition, maybe more high protein fluids and arginine supplements.
Well done. That's impressive in 5 minutes. Yeah. That's good. I actually find on the slide it's easier than the one, but you can actually see there's lots of little broken areas there. And this patient has got a little bit of, incontinence-associated dermatitis on top of it. And they often do go together. So I think skin management with our moisturising is just like a wound, not too wet and not too dry. We've really got to control incontinence as well when we're looking at some of these wounds. Yeah. This lady, I don't think I've got a... this lady, yes it is. So if you look at the skin tear that's at this end of the photo, the little flap there, what category would you call that? So this one here, category 1, 2 or 3? One A or B? Okay, so 1B. So it's a 1 if you can put the flap back where it came from and you haven't got a big gap, which we can pretty well nearly do that. When we look at A or B, we're looking at whether the skin looks healthy or whether it looks bruised and it looks like it might be a bit compromised. That one looks a bit bruised and compromised. So, yep. So all those little classification charts are in your kit there too. This poor lady fell over and actually got a big circumferential tear, but anyway. Has anybody got this foot? I can't remember what else I gave out. No? What would you think would cause that? It could be, but not in this case. Arterial, yeah. So somebody with peripheral arterial disease, look at the toenails, and you can see multiple black spots underneath that fourth toe and on the top there. So somebody who needs to get to a vascular surgeon. I don't think anybody's got this one. Another venous leg ulcer, but a bit inflamed. How about this one? What have we got here? Oh, well done. Excellent.
First thing is, venous leg ulcers typically, it's on the lower third of the
Yep.
body. It's a champagne bottle.
Yep.
We need to elevate it. We need to make sure that if it is producing all that exudate, that needs to be removed. We went through your questions.
Yep.
The answer was everything per chart, which is
Correct.
the thing that wasn't on there is lip grind margins, because we didn't have the documentation of the photo at the same angle, same time.
Yes,
same shot,
yes.
all that sort of stuff for appropriate measurement
Yep.
and reassessment. We also weren't told whether it was a cognitive patient or not.
No. No, it's not. So this patient's all right, actually. So, yeah. Sorry.
She needs the 2 brochures from the kit.
Yes, she does. She does, yeah.
And my colleagues reminded me there's 2 brochures, so she's got the one that she reads for the family.
Yeah.
There's the thing on
The tip sheet, yeah.
sheet.
Good.
Then we wanted to treat the infection, then we had the big discussion about what we do. And I said, you swab it, and they'll go, no, Jill, you've got to clean the top, then you've got to deep probe, not shove it in, but just
Yes.
make sure that you actually do it appropriately. But you can't clean it with chemical. You need to do it with a normal saline so that you're actually getting an
A
appropriate
decent spot,
relief.
yep.
Then
So-
you have to wait for the infection to be treated. So then you have to actually have a nurse and a doctor look at it, because there's obviously a medication involved. Plus we need a specialist to look at venous at the veins, but because there's also association with arterial problems as well, that also needs to be assessed. We needed to have a dressing that will have a moist wound bed
Yep.
that can manage this exudate
Infection. Oh, good.
and protect all the surrounding skin, which will be well moisturised.
Yes.
And then at the end of the day, the big decision is how often will we review her?
Yep.
What do we do if there's 2? Like, is it viral, bacterial? Have we got like 2 things in there? Medications. Then will the medication she take? Sometimes antibiotics don't work with some things that they're on. And if she's on warfarin, it's even more complicated. Because
Yep,
some of the
yep, yep.
antibiotics for the INR.
Mhm.
So big business at that doctor surgery. And then we've got brochures, family education and sport fibre, refer, reevaluate, and dressing and bandage care is a whole new can of worms, because we're all talking about how most of the practices are under financial constraints.
Yes.
All you've got is a band-aid and you've got
Yes. Okay. So this brings up a whole can of worms. You're right. Well done. I'll just quickly a reminder of evidence on swabs, wound swabs. Are our wound swabs of any use? Very little. Very little. So they usually tell you you've got something like Pseudomonas there that you already know because you've already smelt it. And if you are going to take a wound swab, the best recommendation here is you do a Levine swab. Dig, rotate. So you used to, yes, or a biopsy. So either way, it causes pain, and because they're only about 10% accurate, it's probably not something that you would do a lot of. Oral antibiotics for something like that, if she has no systemic signs, again, no evidence to support it. So that person would manage better with topical antimicrobials, unless she starts getting with good education on early signs of systemic infection. Yes. I know.
as opposed to, you know, so it's usually, I think, the nurse's effort to say, please don't prescribe antibiotics, I'm taking a swab, and have it
Well, I guess I could understand that. So, yes. Sorry, I know we're at the end of our time. There's another deep tissue injury. I have my frequently asked questions that I normally have my list, and we've been through most of them. What about biofilm? Are you all familiar with biofilm, and how would you get rid of it? Biofilm needs to be debrided. Scalpel, get your scalpel out, guys. And so if you've got somebody and you can see they've got sloughy wound there and it's slimy, it has not responded to your dressings or your antimicrobial dressing, and it's not getting any better, it needs to be debrided. If you are unable to do some sharp debridement yourself, call somebody in who can. Biofilm doesn't respond to topical antimicrobials, and it doesn't respond to oral antibiotics either. So you really need to actually debride it, and then you've got to put your topical antimicrobials slap on that fresh pink bleeding tissue. And you need to do that every 3 to 7 days until it's better. Sorry?
What about autolytic debridement?
Yes, if it's working. Just some of them are a bit resistant. If it's working, I'd try it first of all for a couple of days. Yeah, weeks. Yes. Yes. Honey. Look it up. There are many systematic reviews on honeys, and they'll be on one of those websites. They're good for killing infection. They're really quite burny, nasty on healthy, clean, granulating tissue. So if you've got an infected wound, stick it on. It's just as effective as any other antimicrobial until it's clean. And when it's clean, stop using it. Some people find it really burns too, so you try a little bit maybe. Yes, so that's how it kills the bacteria. Unfortunately, it also kills the healthy cells. So it's good for if you've got a lot of bacterial there and you want to get rid of your dead cells, but not for the healthy, clean tissue.
Ulcers, nothing you said about rheumatoid.
No. So you'll see on your risk factors there, and it just says complex ulcers, the whole lot. And there are so many of them. If you've got, pyoderma or rheumatoid disease, there are many, many different types of complex ulcers, and it's a whole. I couldn't fit that in today. So, if you look at it, and that's why there's lots of pictures in that DVD, and if you look at the picture of a normal leg ulcer, and then you're faced with a picture in front of you that's got, it's purple, they get these little purple spots or black spots, or the edge doesn't look normal, just doesn't look, the colour's not right, I would refer it off to a specialist to get it diagnosed, yeah.
Okay. So we've
Sorry.
learnt lots today, including moisturise twice a day, I reckon.
Yeah.
Okay,
Yes.
so thank you so much.
Oh, thank
Kathleen.
you. It's been lovely to be here.
We've got
Thank
kids
you.
out of it, and it's a
It's
little
lovely.
kid.
Thanks for having me.